titled Telehealth, COVID, and Funding Opportunities, co-sponsored by Ironbow Technologies. My name is Mark McCormick with the Poly Marketing team, and I'll be your host for today. Please note the Q&A tab at the bottom, where we'd love to have you ask any questions as we go along. We'll either answer them in the chat or bring them up at the end, and if we don't get to them, they'll be answered in the follow-up. Please look for a thank you email from Poly in the next couple of days that will include links to the recording of today's webinar. And now let's meet our guest speakers. We've got Dr. Bernard Harris, Jr., CEO at Vesalius Ventures and former NASA astronaut, Scott Simmons, healthcare specialist at Poly, Mark Mancini, CIO at Little River Medical Center, and Cheryl Henshaw, Director of the Poly Grants Assistance Program. And Cheryl will be our first speaker, and I'll turn it over to you, Cheryl.
Awesome. Thanks, Mark. Oh, and here we go. All righty. So we're going to talk today about funding for telehealth. And I just want to take a minute and thank both Ironbow and Poly for sponsoring this. This is one of my favorite topics. I live in a grants world, so we're at a very exciting time where there's more money available right now than ever before. So it's a good time to be talking about funding. So like Mark said, my name is Cheryl Henshaw. I'm the director of the Poly Grants Assistance Program, or PGAP for short. It says Powered by Learn, Design, Apply. That's my company. I own a grant consulting and management company that contracts with Poly. And it's just a way that Poly gives back and kind of exhibits its dedication to vertical organizations, in this case, healthcare organizations. So basically, it's a free resource. Poly provides the access to my team as a free resource to any organization that's interested, kind of taking a follow the money approach. So I have a team of people that focus on the U.S. And territories, and we basically do research and education on all things funding. So where do I find funding? What grants are the best fit for me? And then to that end, pre-qualification, right? So it's not enough to go, oh, here's this grant and hey, I'm eligible for it. But what's more important is maybe, are you competitive? Are you going to be competitive? Nobody wants to waste a lot of time applying for a grant if they don't have much chance of being funded. So we provide as much or little hand-holding throughout the application process so that people really understand, what reviewers are likely looking for. You get extra sets of eyes when you're editing. We can provide all kinds of information based on our experience with programs and working with organizations across the U.S. So the more people we're connected to that have applied for grants, we get feedback from them and we can share that collective information. And we don't really stop at the submission process. So we probably get an equal number of questions about post-award activity. So how do I get my money once I know I've been funded? Do I draw down funds? How do I file for reimbursement? What do I need to do to prepare for audit? Those types of things. So again, as much or as little help as people need is what we're happy to provide. I want to make sure everybody understands this is a no strings attached approach, right? So there can be no quid pro quo. I tell people all the time, I really don't look at an orange or stripes. So we are rule followers around here, and federal funding, you cannot have strings attached. So just making sure everybody's aware of that. So let's start off with talking about some funding specifically for healthcare. Like I mentioned, there's more funding than we've ever seen available before, at least in the couple of decades I've been looking at funding. And that's due to the stimulus, both the CARES funding and now with the CAA of 21 Act. So in addition to stimulus, there's all kinds of telemedicine funding. Telemedicine funding is generally focused on providing services and support to rural and or underserved communities. So telemedicine, rural used to be pretty closely correlated, and I think there's been a realization, especially through COVID, that you don't have to be rural to be unserved or underserved. You can be in high poverty areas that really don't have access to care or resources either. So that's changing, and that's a great thing. I tell people all the time, if you're thinking about funding follows problems. So when you turn on your TV at night or you're reading the newspaper or whatever, and you keep hearing things like opioid. How many times did we hear about opioid before the pandemic hit, right? It was constant, constant, constant. Even though opioid is actually a small percentage of overall substance abuse disorder, it's the buzz that you heard about. And I told my team when that started happening, there's money coming for that because funding follows problems. And we're in a pandemic world right now, so there's lots of problems and lots of money following it. But in addition to opioid or substance abuse in general, mental health services is another hot topic where there's a lot of money. These types of initiatives are usually funded through agencies like SAMHSA, HRSA, the RUST DLT program, that sort of thing. But they vary. They're focused on different audiences, that sort of thing. So again, grants are specific to who you are as an organization. And we're not going to go into every grant that I know of today. I guess what I want to impart with you is that, we're here to be a resource. So if you want to reach out to us and let us get to know you and who you are, who you reach out to, what your demographics look like, that sort of thing, we can point you in the direction of a grant that's going to be a good fit for you. So in addition to those things, violence prevention and behavioral health have come together in a school focus. And then to expand on that school focus, school-based health is huge and expanding, never been more relevant than it is today. And while it used to be pretty focused on primary care, we're seeing extensions of that now to things like teledentistry, or again, bringing in the mental health and substance abuse component to that. School health is relevant no matter where you're located, but extremely impactful in rural or frontier health, where again, lack of access to care is pretty common. And it becomes not only a school-based health initiative, but quite often they'll expand services to faculty, to parents, and oftentimes to the community. Which is an amazing resource. Last, but again, this list isn't exhaustive by any means, healthcare workforce development. There's all kinds of grant programs that help with, nursing initiatives, allied health, the full gamut of health professions. And, as problems become more prevalent or targeted, you'll see those health professions get more specific as well. So our guidance to people is first, kind of know what you're looking for and make sure you're eligible for it. I wish I had $1 for every person who said, oh, that grant's for $1 million. I want $1 million. And it's like, well, it has to be bigger than that. You have to be eligible organizationally. You have to be eligible in the type of activities that you're promoting, and you have to be competitive, right? So people talked all the time about, oh, I got CARES funding. I'm always amused. CARES like a big old umbrella under which there's lots of buckets. So this is similar, right? There's stimulus funding, there's federal funding, and then more targeted, there's state funding, and then foundation funding, which may be either more regional or more focused, application oriented in what organizations are doing. So can be very specific. And, underneath those buckets, you have just the gamut of healthcare, right? So health reform, rural health, tribal health, you name it. Again, the list is pretty endless. There's every flavor. So it's really understanding who you are and what you want to do that dictates the grant that you're going to have access to, our grants. And I want to be clear about that. It is the very rare grant that would ever solve every need that you have. So we look at grants as a continuum. And frankly, as we get to know you, because we get to know, people that we support very well, we have to understand who you are, what your needs are, that sort of thing. That helps us not only help you through your first grant, but then it helps us watch as grants pop up and go, oh, this would be perfect for, this person. And so, having that continuum of applications going means you're always filling that funnel, and hopefully you're getting funding that comes out the bottom to help you to continue to grow and expand on what you're doing. And, as much at Ironbow and Poly as we like to talk about telehealth technologies because they're exciting and interesting, it's less about the technology and about the way those technologies address a specific need. So, what are the problems or challenges that you as an organization face, or the people that you serve face? How do you quantify those problems? I've had people argue with me endlessly in the DLT program about rurality. Oh, we're rural. Like, well, it can't just be that you think you're rural. You have to be rural by definition of this specific grant program, right? But you may think you have a problem, but when you compare your problem to other organizations like yours, it may not be such a problem anymore, right? So you have to quantify, make comparisons, cite your sources, that sort of thing. And then, grants are always about asking for funding, and there's a budget and a budget narrative in most cases. So you really have to say, hey, these are the specific things I'm asking for, but these are why those things are important and how they're going to solve the problem that I'm talking about in my grant narrative. And then you go beyond that, and you articulate general benefits. So, hey, as a result of this project, we expect these great things to happen. This is how we're going to address that problem, and these are the positive benefits we're going to see. And then some grants are very prescriptive about collecting data and demonstrating that your project has been successful or not, right? But they require an evaluation and data collection and reporting. Some don't, some do. So it's very important to understand up front what the requirements are. Some grants have very, very rigorous reporting requirements to the extent where people go, I don't want to do that grant. That's going to be a lot of work. So just understanding the elements of each grant and, what you have access to and what your requirements are in the back end is really an important thing. And it helps you plan as well. So today I'm going to talk about 2 upcoming sources of telehealth funding. Again, the list of telehealth funding is vast, but I'm going to focus on the 2 that are most eminent, right? So the first is the FCC COVID-19 telehealth funding that should be coming out anytime now, round 2. And then my favorite grant, the USDA RUS Distance Learning and Telemedicine Grant. So the FCC COVID-19 telehealth funding program, it's exactly what it sounds like, right? It's funding that's there to fund specifically telehealth equipment, licensing, that sort of thing to address COVID in some way, directly or indirectly, right? So this grant popped up as part of CARES in response to the pandemic with a realization that, oh my God, viral spread was such a concern. Healthcare facilities had to shut their doors to most people, right? Sometimes turning away like emergency care because they were worried about viral spread, right? So they really just wanted to see COVID patients. And so they put this grant program out to kind of go, hey, telehealth can help not only address the needs to, identify whether or not somebody has COVID, so testing and treatment and things like that, but it can also help us address the needs, the healthcare needs that people continue to have even though there is a pandemic. It doesn't matter that, hey, we don't want them in our hospitals because there might be viral spread. We still need to provide care. So that's what this grant was about. And USAC under the FCC is the agency that or the organization that ran this program. USAC is the organization that funds like the E-rate program or the rural health program, and these are telecommunication discount programs. So they're more applications. So here's your application, here are the rules, do it properly, submit it between this date and this date, and you'll get funded. If you do things properly, you're going to get your discount on your telecommunications costs, right? And their COVID-19 telehealth funding program, they're very quick to say, oh, this isn't a grant, but it sure looks like a grant. It has a lot of narrative component and things like that. So when they decided to take on this program, I think they approached it more like an application for discount rather than, what would be more traditional, a grant, kind of program. So they asked for narrative components, and they weren't very clear on what they wanted. And, sure, they tried to get it on the street quickly. It was meant to be reviewed and funded quickly, and, that was amazing. But in the process of doing this in such a hasty manner, they left a lot of questions out there, right? So when people started to apply, they hit all these speed bumps. And because my team has a national focus and, we work with organizations large and small across the country, and really handhold, like we would be on calls with them as they're getting into their portal for the first time and stuff. We were hitting these speed bumps together, and we'd figure out a workaround, and then, we would share that information. And it wasn't very long, like days, not weeks, before we really started collecting all this information on, hey, how do we crack this nut? What's the best way to really address this program? The national reach and kind of communication gave us unique insight, and we created our own set of reference materials, which kind of went viral. We had people calling us from all over. We had no idea how they found us, but really just, oh, can you help me? And that's what we do. So we touched so many of these projects and really had an amazing success with these projects. But I think speed bumps that FCC saw, obviously, in round one, and maybe some complaints they received, will inform the second round of funding. And so we believe this will be out very soon. So there's $250 million that was in the Consolidated Appropriations Act of 2021. $50 million of that is slated for administrative purposes. So essentially $200 million is available for awards. You can request up to $1 million per person. Now, the FCC, you can tell they really thought through like some of the changes they may want to make, because actually in the act, they talked about the fact that they were going to put out a public comment period, which just ended last week on the 19th. And as part of these public comments, they really led you, we're thinking about this. Can you respond to these issues, right? So you can see what they're considering and kind of where they're going, but they're in the process of reviewing those comments right now. And then they should put their grant guidance out. Hopefully it'll be a little more informed than last time. And then we'll see exactly, kind of what that looks like and what changes they've made. One of the things we do now is they're looking at better geographic distribution of awards. So, again, you can apply for up to $1 million. And so they want to have at least one award per state. So you could essentially say, 50 million can be set aside right off the bat so they can ensure at least one award per state. Up to $50 million. One of the questions that they asked people to comment on was, should we have rolling applications like last time, or should we have an application window? So like a traditional grant program where, you can start applying in this date, and here's the last day to apply, and then they review all applications at once, and then they put out awards. My personal belief is that, while I get where there's merit in that, the intent of this program is to get money on the street quickly to address COVID. And, the rolling application process is probably a better way to do that. So anyway, TBD. Previous eligibility under the first round, we believe will be the same as the next round. It'll be limited to nonprofit and eligible healthcare providers, so no for-profit hospitals. But these are great projects. Again, they need to either directly address COVID or indirectly address COVID. Definitely, they're looking at providers who maybe are safety net providers or provide support for, unserved or underserved areas. So that's a key element as well. We learned lots of tips and tricks with this grant, things you wouldn't normally think about. Like they would provide in the online portal, they provided like this little tiny text box. And I think people thought, oh, well, they just want one or two sentences, and what they didn't realize is some people provided pages of information. So that text box will expand, right? So more is more. Give them enough information to fully vet your project. And especially if it's going to be competitive this time, definitely fill in anything, even if it says optional, fill it in. They asked people to comment on like the number of patients they were serving. And some people put in, well, here's the population I serve, and other people put in things like, we anticipate we'll see, 200 patients. Well, other people got smart and included as much information as possible, and they started projecting things about patient encounters. But what the FCC didn't make clear is that when you ask for things in your budget, it needed to align with the number of, patients or patient encounters. So they started sending questions back. People lost their place in the queue when they submitted because the FCC would come back and go, wait a minute, you said 200 patients, but you've asked for 10,000 licenses here. How how do those things line up? And so people would have to come back and add more information. So again, we have lots of lessons learned. If you have any interest at all in this program, contact us. We are happy to share all that info with you and kind of, again, handhold and share, learned experiences across the country as the next round of funding is available. So on to the DLT grant. This is my number one favorite grant, maybe just because I've been doing it for more than 2 decades. I have a love-hate with this grant program. So we do anticipate an early February, maybe as late as April release. Generally comes out this time of year, but we're in the middle of COVID and nothing is normal at this point. The application is generally 60 days. The award size, just like FCC, is up to $1 million. There is a 15% match required, and that's the match between the ratio between your match and your federal fund request. So it actually amounts to about 13% of your total request. So basically, one of the exciting things about this grant is any organization other than a sole proprietor and a federal organization essentially can apply, as long as you're proposing to deliver some flavor of distance learning and or telehealth to rural areas. So again, DLT is pretty prescriptive about what they consider rural, and that you certainly can't have an end user site of more than 20,000. But for anybody who does any kind of rural outreach, this is such a perfect grant. It's very competitive, but we've worked on this grant for so long. We have a very, very high win rate and can definitely provide guidance to help you understand how to be funded. So this grant has objective and subjective scoring. It prioritizes rurality and poverty and that unique mix of rurality and poverty. And then it has special consideration points that sometimes are aligned to economic zones or maybe a project focus like substance abuse disorder or specifically opioid or STEM education, that sort of thing. And again, very broad definitions of STEM, by the way. So this grant is very broad in nature, which makes it really exciting. It is a CapEx grant, so it's really focused on equipment and associated services, software and licensing, that sort of thing that's required to put together or augment or refresh a distance learning or telehealth network. The T in DLT does stand for telemedicine. Again, very broad connotations. Any flavor of healthcare fits the telemedicine requirement there. So there are so many other discretionary grants out now or that will be due soon. I'm not going to go into all these. We simply don't have enough time, but I threw those up there just to kind of let you know there's money out there. There are grant programs out there. Whether or not you're qualified or if it's going to be a good fit for you really is based on who you are and what you want to do. So feel free to contact us and we can kind of, develop that understanding of what your needs are, and then we can help you find a grant or grants that are a good fit for you. The pandemic has created tremendous need and a place for telehealth like we've never seen before. So, I've been a big proponent of telehealth way before the pandemic, but it's never had its moment in the sun. There's been barriers in place that I know Scott and team are going to talk about that kind of went away or at least dissipated a bit during the pandemic. And I think the cat is out of the bag. I think telehealth is here to stay. And I think that people are now realizing telehealth really has a place in our future, as we move to our next normal. So I was on a call a few weeks ago where somebody said, never let a good crisis go to waste. And I thought that was so funny. They're really talking about the fact that there's so much money available now, and they're trying to be thoughtful about using money that provides impact during the pandemic, certainly, but impact that will also be impactful moving forward. So as we move into the future, what are those things that I can do that are going to help me grow as an organization or provide better outreach, to the people I serve? So again, this is the tip of the funding iceberg for sure, but I want to get on to the best part of our presentation, so I'll leave it at please feel free to contact us at grants@poly.com if you have any questions or would like to have a further conversation about funding that's due. The funding is always the cherry on the sundae. It's not about the funding. It's really not about the technology. It's really about the impact that these technologies can make and to address your needs and help people. So Scott, I'm going to turn it over to you.
Thank you, Cheryl. And I'm very appreciative of your presentation, and as well as having Mr. Mancini and Dr. Harris with me today. Just a little more background on my two co-panelists. So Mark Mancini is the CIO at Little River Medical Center, which is a FQHC network, or Federally Qualified Health Center network, that serves rural parts of South Carolina and North Carolina. And he's been involved in telehealth for a while. And Dr. Harris, as we mentioned up front, is a physician and a former astronaut, but he's also past president of the American Telemedicine Association. He and I got our start in telemedicine in the space program, but what he's doing now and why we asked him to join us today was for two reasons, one of which is he went back to school when he left NASA and got his MBA, and he runs a venture fund. So I thought the investment community perspective on this, and his fund focuses on health technology companies, and he's also a philanthropist, so both through the Harris Foundation and Harris Institute, but he's also recently become the CEO of the National Math and Sciences Initiative, which is focused on improving access to quality STEM education. So it's amazing, and I think Mark and Bernard will echo me on this. I've been involved in telehealth for close to 30 years, actually slightly over 30 years. And it took COVID for my family members to know what I actually do for a living, right? Because they're actually, my mother-in-law and my wife with my children are actually had to do virtual visits during COVID, and they never have before. And suddenly the light bulb went off for them. And, I've been saying for the last 25 years, this is going to be a year that telehealth really takes off. And it was this black swan event of COVID that, and I finally made it happen. So maybe I'll start with Mark to get his perspective on kind of the effect of COVID on his operation and the things that they had to change to respond to COVID and as to what they were doing in telehealth.
Well, thanks, Scott. We started with telehealth about 3 years ago. And back then it was very different. We started off with a school telehealth program. We had to reach out to the schools in our area and sell them on the idea of telehealth. And it was an uphill battle. The pilot program was just in 2 schools, yet we had 18 carts coming to us from Ironbow and Polycom. So we had to quickly ramp that up. Well, as soon as we got involved with 2 of the schools, COVID came. So we had to pull these carts back into our clinic because what changed was the physicians and providers not wanting to touch the patients, and rightfully so. We don't want our providers getting ill and falling down with COVID because we need them to see patients. So it became the nurses operating the carts while in the same clinic physically as the providers. So they would use the scopes and so forth and the telehealth cameras on the providers' laptops to see the patients. And it kept providers at a safe distance, got them the care they needed, and it also allowed us to bill at full rates because it was done on the same premise. It was not a telehealth visit.
That makes a lot of sense. So Bernard, you've been in this telehealth space for a long time. What's your experience been, or what's your impression of kind of this catalytic event of COVID and how it's changed telehealth? I mean, you can take it from the investment community perspective, or legal and regulatory, or just the kind of the market in general. Dealer's choice.
Yeah, thanks, Scott. And I have to echo what Cheryl said a minute ago. I think telemedicine and telehealth is here to stay. The genie's out of the bottle. You mentioned earlier that, you and I go back to our NASA days where we were developing a crew healthcare system for space and for the International Space Station. So that's how we got involved in telemedicine, true distant medicine, or remote medicine, as it were. I've been involved in the investment space since 2002 when I started Vesuvius Ventures. And we were probably one of the first venture capital firms that were out there advocating telemedicine with this premise that the way that healthcare was going to go, and I'm not alone in this statement, but telemedicine, telehealth would be a tool for delivering healthcare. and a most effective and efficient tool for delivering healthcare. And so I was echoing that sentiment, both as an investor and, as you already mentioned, as the president of the American Telemedicine Association. All of us were big advocates. And I remember us having a discussion that said, one day we're going to put ourselves out of business by advocating for telemedicine. Well, that day is getting pretty close. And with COVID, it really has changed the mindset of how physicians are looking at telehealth and how patients, as you just said, are looking at telehealth. And certainly when you have such a appeal from the masses, the patients and the physicians, you attract investors. And so you have seen over probably the last year or so, a lot of acquisitions. And I just listed a few, if you haven't heard. But Teladoc has acquired a number of companies, including what's Yulin Long's company? I just lost name. Will come back to me in a second.
InTouch Health.
InTouch Health. Yulin will be upset at me because we've worked with him for a long time. Specials on Call, for example, is also going through acquisition and looks like will be part of a large organization. Second MD, a company based here in Houston, is going through some growth. And just recently, last week, Preventus, which is an ambulatory cardiac monitor, just got bought by Boston Scientific, just to name a few. When I look at this space as an investment strategy, we have a lot of different telemedicine offerings that are out there, telehealth offerings out there. So it's a fragmented market. And so from an investor standpoint, I think it provides a tremendous opportunity for us to take telehealth and telemedicine to the next level.
Thanks, Mark. And so, Mark, what's your take on the legal and regulatory environment? Because I think a lot of the catalytic effects were not just the funding that Cheryl talked about, but the changing of a number of aspects because of the national emergency, whether that's parity. In other words, parity meaning that the telehealth visit for the equivalent face-to-face service is paid at the same level. Like before, that wasn't happening. So if I just needed to talk to a physician for some particular thing and there was no reason to be face-to-face, but I did that by the phone or by video, I got reimbursed at a much lower rate than I did if I actually went into the office. So in a way, there was kind of a perverse incentive to not use telehealth because I get paid way more if someone came in my practice. Are there aspects of that, either legal or regulatory or reimbursement policy, that really made a difference for your practice, Mark? I know it's different with FQHCs, but can you comment on that?
It's very different for FQHCs. Prior to COVID, we were not getting reimbursed for a telehealth visit. And thankfully that changed. And luckily in our state, we have great Senator Tim Scott, who's a proponent to extend the telehealth payments for FQHCs beyond COVID, because not only is it needed, patients are asking for it. And we serve the underinsured and non-insured, and it's not fair that they shouldn't be eligible for it. So one of the issues we do have is technology, and while we're in the Myrtle Beach area, it is rural, and there are some parts of our county that internet is just simply not stable. 4G is just not the speeds you would think in some of our impoverished areas. So it is a challenge sometimes with that, to kind of answer your question in a roundabout way. But the reimbursement is something that's important to us because we do need to recoup some money from Medicare and Medicaid. And the phone visits, I think, were $12 a payment for a visit. Telehealth now, again, it ramps that up quite a bit. So I have my faith in our senator that he'll push this forward and hopefully extend this, because for us in the FQHC arena, it's important for us to survive.
All right, thank you. And the interesting thing about that is that if you really look at the health system, I'd ask Bernard to comment on this too. If you look at interaction with the health system, just personally, I bet everybody has a personal story of they're sitting in, they have to take off time of work or take their kids out of school, and then they wait in the waiting room for a long time, and then they get in to see their physician, and they spend 5 or 10 minutes with the physician, and you're going, why did I need to come in to do that, right? So this, to me, this reimbursement parity is huge for people to be able to rethink what's necessary in an office visit, and what we've seen because of COVID is a lot of people have already kind of mentally changed into that mode just for reducing the infection, right? The infection risk. So people are already kind of triaging, well, what do I really need to see in person? You know, what do I have to put hands on and physically examine versus what can I handle remotely? And Dr. Harris, any comments on kind of clinical use cases and applications that this has really opened up or have emerged?
So I'm going to use an example that you might not think of for telemedicine. I sit on the board of U.S. Physical Therapy, one of the largest physical therapy companies. So when COVID hit, we had to make this shift. You know, there was nobody going into the clinics whatsoever, and so we still need to provide services. So we shifted to do telemedicine services, so telehealth services. And I remember probably 10 or 15 years ago going to the CEO and said, you know, have you thought about doing telemedicine, physical medicine, using telemedicine? So no, you know, we're a hands-on type of company. And lo and behold, that was our savior. It became a large portion of our revenue in this past year. Now, things are coming back and opening up, but we're going to forever have a telemedicine practice because it just makes sense from what you just said. I think there are going to be, you know, when we invest, when we talk about headwinds and tailwinds, and so, you know, we had the headwinds for adoption of telehealth and telemedicine was reimbursement and was physician, you know, and both physician and patient acceptance. What COVID has done for us is sort of taken off the blinders to say, hey, look what the capability, look what the different things that you can do. And the example of physical medicine, you know, physical medicine using telemedicine, it doesn't make any sense, but it works, right? So you can easily apply that to other disease processes very, very quickly. And then the last thing I'll say is the behavior, consumer behavior has changed dramatically on, as you just mentioned a minute ago, on the acceptance of doing things remotely or online. And that has opened the door for a lot of different opportunities. One of the exciting opportunities that I'm currently involved with is something called the ABLE channel. The ABLE channel is the first health streaming channel. Now, why is that important? Because people now are going not only to the internet, but they're going to the streaming channels for information, for entertainment and information. And so we're seeing that impact when we never thought that that could be an opportunity here, but it's opened that door. And for me, that's really exciting. And then just the last thing I will say is on licensure. You know, right now we have a waiver in place that allows us to practice. This has been a big initiative of mine, personal and professional, to push for national licensure, which is another headwind. And now that headwind has gone away. When COVID diminishes, may not go completely away, I think our licensing boards are going to have to ask the question whether you know, we should continue doing these state licensing physicians and nurses state by state. It has to change. I think it will change.
Well, I'm glad you mentioned that aspect because we had not brought that up before, and it's, you know, it's interesting. I'm going to be careful what I say here, but state boards of medicine have been reluctant to adopt telemedicine or endorsed telemedicine, it's usually been couched in patient safety terms. We care about the patient. We care about patient safety, so we can't do that. When in fact, I think some of the issue is fear of competition. Right? It's like if I am the only specialist in a certain specialty in this county that's on the border of another state, I've got a nice practice, right? I don't have to. I've kind of got a little mini monopoly in my 3-county area. But if I can see that a specialist from any state, right, then that kind of opens up the competition. So I won't push on that one too hard, but yeah, absolutely licensure. So you think there's impetus for that improving post COVID? Because that was the last topic I kind of wanted to get in, is what kind of your big predictions and since you and I were just talking back and forth, maybe you start and we'll go to Mark, and then I'll give some of my own on what's telehealth look like after COVID. Like you said, we may never completely come out of the COVID situation, but what do you think? What stays and what doesn't?
Yeah.
What does it look like?
Yeah, I think that telemedicine is going to be a important aspect of your practice, no matter what specialty that you're involved in. It's just going to become a component of your practice. So you'll have face-to-face encounters. You still, and those encounters either will occur in the clinics or in the hospital. But the follow-up and some of the primary encounters and secondary encounters will be delivered via telemedicine, telehealth. So you think about, the Poly and Ironbow, which I'm very familiar with, 2 companies, providing hardware to support that means that, you're going to have increased business because of that, because, you're going to have hospitals and practices that will need to have that level of support. I think that it's going to expand dramatically over the next few years. And just to put a pin on the licensure issue, I think that this COVID and what's happening in healthcare right now and how technology is being utilized is really going to push us toward a national licensure. And by way of just an example, I think the AMA and the American College of Physicians have been supportive of telemedicine, and that's taken a few years to come around, but they had no choice.
Well, it was amazing how responsive the American Medical Association was in COVID, because I know they put out these reimbursement guides that were very definitive on how you should code and all that stuff. And it's interesting that the national emergency is going to continue for a while, at least for the next. The declaration will continue for a while. Yeah. But I know the guidance that came out from CMS for reimbursement for Medicare was very telemedicine friendly for the whole year, right? And then now there's different states, like the state of New York, and I think I saw the state of South Dakota, and other governors and in other states are now pushing for expanded access to telehealth and expanded reimbursement. So it's likely for that to be sticky, I think, too. So I think that's somewhat of a relief. Mark, what's your take on the post-COVID outlook for telehealth?
Well, I'll agree with that in just a second. I think Dr. Harris will appreciate this. If I were to be in my parking lot of our health center in Little River and you threw me a high fastball, I could hit that baseball into North Carolina. So we're right there on the border. So at first it was our billing department had to deal with how do we bill this for our patients right over the border when the service is here in Little River. So it definitely becomes a question of, should we look at this at a state level or a federal level? So that was an excellent point you made. The future of COVID, I'm an optimist. The glass is half full and it could be refilled. I think after this year, we'll bounce back. But I do think telehealth is here to stay. I mean, no doubt, whether it's in the FQHC space or anywhere else, I think the government stepping up with these grants is huge. And everyone on the call needs to jump on board and start now, because it does take some time to roll everything out. Now there's a lot more in place. You have webinars, you have sites, you have consultants to help out. 3 years ago, we didn't have that. We won it ourselves. we learned on the fly, and it wasn't easy, but we were able to do it. I think I do have to give kudos for Polycom and Ironbow for their help with this Rust grant that we got and getting us those telehealth carts to all of our clinics and also to the schools, because without that, we wouldn't be in the situation we were. We were fully prepared when COVID struck, and that was only because my CEO, Pam Davis, had this vision of telehealth that she got when talking with MUSC when she was down in Charleston, and the future they were already looking at telehealth years before that, and that kind of got the ball rolling. So 3 years to get started with telehealth. I'm a veteran in it, and I've only been doing it 3 years, which is kind of odd.
Well, just
with an astronaut, so go figure.
Well, and we're going to transition into Q&A here in a minute, but I think I would close with this observation, because it's something I know we've studied and observed as a company, is this kind of a whole, not just in healthcare, but the complete rethinking of what work means, what the workplace means, or what school means, or the site of education, right? And there was a study I saw cited the other day. I don't have the reference in front of me, but it was, I'm estimating that even still in 2024, that 30% of the global workforce is going to be working from home, at least part-time, and another 30% full-time, right? So what does that mean for the medical, what does the medical office look like? What does the hospital or the health system look like if you've got remote workers, and how do you incorporate technology to deal with that? What does, how do you provide healthcare services to those people that are working from home or at home in that? And so I think this is, like you were saying, I think there's this whole redefinition of how we live and work and interact, and it's really a time for change, right? So I think so many organizations, and this is somewhere that's a good use of these sorts of grant funds, is to subsidize some of this innovative thinking and kind of reforming and reframing what your organization looks like in the future. So Mark McCormick, are you going to be sending us the questions or reading the questions to us that are answered?
Well, we've had a few that have come in, and okay. Mark, this is specifically one for you. First, there was a quick shout out for thanking you for representing FQHCs from northern Wisconsin. And what are your typical connections these days? Are they mostly clinic to clinic, clinic to home? Kind of what is your current telehealth program? What are most of the connections?
So right now, I'd say it's split pretty evenly, but it's ebb and flow different ways. So we use a clinical work, so we have Helo as our telehealth for our home visits. But when it's site to site or site within site, it's the Ironbow cart. We use the Polycom codec in lieu of the Cisco codec, and utilize that technology. The Polycom Ironbow is a good mixture. The Ironbow cart provides you the scopes, so the providers can get into the orifices if need be, or the derm scope to be used, and the Helo is strictly audiovisual. But for many patients who have COVID symptoms, it's usually all you need, and then they're prescribed whatever the doctor says fit.
And this question would be for you, Cheryl. How do you find out when the FCC COVID-19 telehealth funding for CAA 2021 info is posted and available?
Well, I'm on every listserv you could think of, so I get pinged every morning. I pretty much roll over in bed, pick up my phone, and start tracking like the Federal Register and stuff like that. But my team will push that information out through, Poly account managers, through our partners like Ironbow. We'll make it available on websites, that sort of thing. So we'll make sure there's a broadcast that the funding is available, and we'll start educating on that.
And a follow-up question, Cheryl, from another attendee. Can you talk a little bit more about the matching requirements for a Rust DLT grant program? What can I count on as match?
No, cash is king. Cash match is where you want to go. will the program technically accept in-kind match? Yes, but again, the definition of match in Russ's eyes and other grant programs is very different. And essentially, you have to make the purchase from a non-federal source after the grant due date, and it has to be woven into the scope of your project. So it's almost like cash match, right? So best guidance to anyone is try to find cash match. And if not, we can talk you through some other options, but definitely cash is your easier route.
And even an additional one follow-up, Cheryl, for you, for the upcoming FCC COVID telehealth program, since we don't have the details and the guidance yet, what are some things that someone could do to prepare ahead of time for the program to be ready to submit?
Great question. So USAC has you create an FRN, and then they want you to establish eligibility. Now, these are all grant technical terms, so I apologize. You have to fill out a Form 460, not that makes any sense to anyone, to establish your eligibility. They've waived that requirement prior to submission for the second round, but you're still going to eventually have to do it, so you might as well just go ahead and do it. But I'd also start thinking through, again, what are my needs? So how am I going to quantify my needs? Who do I want to connect to, and why? Why is it necessary? And then most importantly, what are those items that are eligible, to spend the funding on, so I can go ahead and get quotes and think about the cost of my project and start to align my budget justification with what I'm going to ask for. So all those things are things you can be doing now, and then we can refine once we have the details of the grant pop up. And Mark, I just wanted to let you know I answered a couple of questions in the Q&A, and so if you want to, if we have enough time, you can go back and read those, and we can address them on, verbally.
And I looked through the Q&A too, and it seems like a lot of them are about some details about the grants programs. The best thing you can do is get in touch with Cheryl's team, to answer some of these things. And I wanted to make sure that we had a little time left for me to just thank Dr. Harris and Mark and Cheryl for being with us today. Bernard, did you or Mark have any closing thoughts or comments that you wanted to make before we wrap this up?
Yes, and I'm glad that you have put this conference together. I think this is really good. It is nice to see that there are grants out there that kind of help telemedicine, telehealth continue to grow. And personally, I think I'm looking forward to where we will be 5 years from now in healthcare, in the medical space.
The only thing I'll add is simply go after the grants. We've gone after a couple more since the Russ grant. One we didn't get, and I think 2 we're in the running for. So, and one's looking very promising. So you definitely want to apply for these. The money's there for you to go after and use. And if you're not doing telehealth, please do. Don't wait. This will be the future. This isn't something that it's just for COVID. Anticipate this being part of our mainstay. And one thing I want to close on is years ago, CVS started with this minute clinic with getting providers out to all their locations. Well, this just hopscotched right over that and brought it right to your home. So I think there's a whole lot looking forward with this, and I'm very fortunate to be part of this time. I think it's if you're in IT, it's just a rewarding time to be a part of.
So would you agree? I just saw one question pop up then. That Dr. Harris said telehealth is here to stay. Does Mark Mancini agree?
Absolutely.
And nobody asked, but Scott Simmons agrees too. And the other thing too is as Poly and the PGAP, our grants assistance program, work hand in glove too. So I'm available as a resource as well for people that are trying to ideate how they roll out telehealth. I've been doing this for implementing telehealth programs for close to 30 years, and we have a vast array of resources, not just on the funding side, but also on implementation and best practices. Actually, we and Ironbow both do. We have subject matter experts available to help people as well. So, any closing thoughts, Cheryl?
Yeah, I just have one comment. I think a piece that we miss that I think is probably most important is that I think there's been such an acceptance by the public. Like everybody kind of got forced into doing telehealth and people like it, right? They have a little taste of it now. They're not going to want to give that up. So I think the public demand is actually going to push states to change their views on licensure, and it's going to help broaden reimbursement and things like that. So I really do believe telehealth is here to stay.
Well, that's a great way to close. So thanks everybody for their time. Thank you in the audience for your attention. Mark McCormick, any closing instructions for anyone?
No, just another mention that we will send the recording out to everybody, and sincerely appreciate everybody participating today.
Okay, thanks to all. Thank you.
Have a great day.
All right, cheers.
Thanks. Bye-bye.